you have at least acknowledged it.
And so is there something about like, so let's say someone comes in, they're a new powerlifter, but they've been training, strength training, and even maybe they had some sort of previous back injury.
Yeah.
It could be, it's a talking point. Let's go over it. What bothers you? And then potentially some education on, no worries. Like when we see things like this and if there ever are flare-ups, this is how we deal with it. And showing them like, hey, we have the education to deal with this. This is what we recommend. Are we allowed to say that? Like, should we even go there? Or just, cool, like, thanks for sharing this with me. We're going to do we're going to do our best to keep you healthy and safe and move on.
If my opinion is that is, if it's within your skill set, it's within your scope, and it's absolutely a reasonable approach. If you want to add the caveat of, if it becomes something that we as coaches don't feel super comfortable managing, that we have some healthcare providers that we trust who understand powerlifting, and we'll have that conversation when need be. But we as coaches, just real quick, you guys deal with it. I mean,
we do. We're the first line of defense.
Everybody I coach
raise your
is
hand
injured.
if you've gone 2 weeks without a client coming up to you and saying, hey, this or that.
I don't
have any clients, but I deal with them all the time.
I don't talk to my clients more than once a month, so I'm not.
So once a month for you.
2 weeks is I
I
haven't heard anything bad in the last 2 weeks. Seems fine. What from a like kind of practical standpoint? Let's say we're coaches and we want to try to integrate to some degree with clinical athlete. Mm-hmm. Even just from a perspective of like, hey, I've
jumped the gun, dude. I had no. Go
on.
Oh,
okay. Like I have that sort of like, I know I'm going to need it at some point, but like I find that like I'll have athletes and they'll get hurt and it's like, you just kind of don't know what to do sometimes. You're just like, okay, well, go to the doctor. And that feels like such a poor handoff. Like you're not really delivering anything useful. I will recommend like, reach out to Quinn Henoch or whatever. But like, is there a way or a channel for that to happen for people?
So this is a very mechanical, so I won't spend too much time on this, but we used to literally have a map online, clinicathlete.com. It was the clinical athlete directory.
It was the same as a NAMBLA map, right?
Oh, God. Don't do it.
I'm just kidding. Sorry.
It had everybody on there who was a clinical athlete provider.
Yeah.
So that public directory is not currently public right now because we revamped the entire process of how to get on the directory. Like we made it way harder, and we put people through this 4-month gauntlet to actually call themselves clinical athlete providers. So the directory is internal now.
Okay.
So but the process would be the same. Like you reach out to us, and we have a very vast network, and it's very likely that we have somebody in your area.
So people don't necessarily have the ability to look up a clinical athlete clinician on your site, like by map. I remember the map.
Correct.
But
Not at the moment, no.
Okay.
They get paired up if they enter
They could find
like
it,
a lead
though.
form. They'll enter a form. Someone will reach out to them, pair them up with the local clinician.
Yeah, exactly. And honestly, we have many, depending on your desired activity, like whatever your niche is. We also have probably several digital PTs who could help you, like in conjunction with your in-person coaching and gym. That would probably be as effective as you having to go to another clinic, to another place during your week. So you've got lots of options, and obviously that doesn't have to be local.
Right.
So I have a question. So one of the things that we talk about with Coach Logic a lot is like the data that we can track. Average weight, peak weight, volume, intensity, all this stuff. Mm-hmm. I don't know if you can answer this, but like, is there a data point or metric in that group that matters the most whether it be with injury prevention or a dial U-turn when it comes to getting someone back? Like what would you adjust, or what do you look at?
I guess, I think the principle is, if you're trying to standardize something and actually monitor, you've got to just try to standardize the variables as best you can. So I differentiate between an embedded test and more of a formal or standardized test. So like in physical therapy, for example, we might hook somebody up in this dynamometer chair and like strap them in there and just have them kick their leg out against this pull gauge, and see how much force that can generate. But that's not their training. That's a standardized, formalized test that gives us a very specific information about that particular task and that particular system. And that's useful, but then it only transfers to our knowledge so much in terms of the overall training. So the embedded tests are the exercises themselves.
Right.
The squat, from a performance perspective, like we talked about, what is your estimated rep max going up based on the loads that you lift and your RPEs, or however you're measuring that. And so if you have some embedded tests that you can standardize to some degree, like they execute the movement in a similar fashion, rep to rep, that you can kind of say every couple weeks, all right, let's hit that like 10 rep max or 8 rep max or 5 rep max on this particular movement that is relevant to what they have going on. That can be an embedded test. And within that, if pain is involved, then it can be what I'll define as tolerance. Let's try to define your symptoms. I will have them quantify meaning to symptoms. So I'll use the 0 to 10 scale as a way to gauge. So 10s, we're going to the hospital, 0s, no pain. But I qualify, has there been a scenario where you felt your symptoms, but they didn't change the way that you execute the task? And they say, yeah, like it's kind of there sometimes, but I can still move and put force into the ground the way I would normally. That's like a 3. I'll say, okay, cool. 3 is where we're okay with living. Now, has there been a level of discomfort that makes you change, either consciously or subconsciously? You do something wonky to try to avoid it. You shift. You can't put force into the bar like you normally would. They say, yeah, that's like a 6 or a 7. I say, that's where we don't want to live. But if you're 3, if you're able to handle more volume, more external load over time, staying at 3 or lower, that's progress.
Got you.
If same load, same volume, but hey, it was a 3 on week 1 and 2, but we're 4 or 6 weeks in now, and that doesn't hurt anymore. It only hurts when we go heavier.
Right.
And so you could pick 2 or 3 movements within their program and define tolerance that way.
Got you.
As an embedded test.